Thank you for the opportunity to come here to Brazil and speak about something that's very dear to my heart, and that is treating patients with schizophrenia and chronic psychosis. It's something that I deal with on a daily basis. I run a 24-bed inpatient unit that focuses on the research and evaluation of patients with chronic mental disorders, particularly schizophrenia and schizoaffective disorder. We also have patients with bipolar disorder as well. And today I'll be talking about actually one particular molecule, and that is quetiapine, and talking about the evidence that supports its use in the treatment of patients with schizophrenia and bipolar disorder. But I'll use a historical perspective. And my first exposure in prescribing quetiapine was actually before the drug was released commercially. We were involved in a clinical trial prior to registration of patients with refractory psychosis. And we would compare, it was a double-blind randomized clinical trial comparing quetiapine with a first-generation antipsychotic. And we were dosing quetiapine blindly up to 750 milligrams a day. And I think pretty much every patient that was enrolled in the study, we went up to the maximum dose in the flexible range, no matter what they were randomized to. So you can imagine my surprise when quetiapine was first launched in the United States in 1997 that we were told to prescribe it to a dose of 300 milligrams a day. This didn't make any sense to us, and we saw that this drug was not being used very much for a couple of years. The 300 milligram dose was actually far too low. And over time, we've gotten additional clinical experience on how to dose this drug properly. So I'm going to go over the historical perspective of using quetiapine and using slides that were used years ago to promote quetiapine and how those have changed as well. This is my disclosure. I have relationships with a number of different companies, some of them very large, some of them very small. What we depend on our research unit is funding from the government, from national agencies, and contracts with pharmaceutical companies so that we can do all the research we want to be able to do. So the evolution of quetiapine is kind of interesting. It was released in the United States in 1997 for the treatment of schizophrenia. And there were subsequent approvals for other indications, notably bipolar mania and then bipolar depression. The extended release formulation then came afterwards, and that also got approved for the same indications. There are other indications that the Food and Drug Administration has entertained. A decision has not been finalized, but in some countries it's approved for other disease states as well. But what has really changed and has made an impact, and why quetiapine is actually used a lot, is we know how to use it. We know how to dose it. But that did not happen overnight. This is an old slide of a promotional material that described how patients with schizophrenia can be maintained with quetiapine in open-label extensions to double-blind clinical trials. And it demonstrated that improvement occurs over time. Now, I see this as somewhat, reassuring that patients improve acutely, and provided they remain adherent to medication, they continue to show improvements slowly but surely in positive and negative symptoms. What is in small print at the bottom of the slide is the mean dose of about 500 milligrams a day. Now, this is quite striking because this was used in promotional materials when the other discussion centered around, we need to dose quetiapine to a target of 300 or 400 milligrams a day. Yet, the open-label extension trials told us, when you maintain someone on quetiapine, you actually dose it somewhat higher. Quetiapine, looking backwards, actually is an efficacious drug. Compared to placebo, it shows superiority. This superiority in the treatment of psychosis can be seen at the week 1 time point. This is also very reassuring, but we also need to know how long to use it, at what dose, and so on. Other issues that have come up is what about other disease states? And sure enough, other studies were done. Now, the dosing of quetiapine in product labeling is still kind of restrictive. In the United States, if you read the product label, it still tells us to start at a low dose on day 1 and to titrate over several days to a target of 300 to 400. The Brazilian instructions are actually a little different and suggest 600 milligrams a day is quite reasonable on day 6, and when appropriate, you can go up to 800. In the US, this language is not so clear, and that led to really a very slow adoption of quetiapine until more clinical experience was accumulated. Now, the extended release formulation, different. It's different in the instructions and how to dose it and how to titrate it. Let's take another step backwards and take a look at how we've used quetiapine in the real world. And my real world is a state hospital. And in the New York State hospital system, we have 16 of them. 16 state hospitals, 5,000 beds, and about 10,000 patients treated each year. One of the things we can do is look at all the prescriptions written for each of these patients, looking at which antipsychotics are prescribed, which anticonvulsants, if lithium is prescribed, what combinations are used, what doses of each are used. And we've been using this database for a variety of these observational retrospective analyses. One of them, which was published as the cover story in the Journal of Clinical Psychiatry a few years ago, looked at dosing of quetiapine in our real world of the state hospital system and how it differed from the registration studies, how it differed from AstraZeneca's initial recommendation that we need to dose it to a target of 300 to 400. Now remember, our own personal experience, even before the product was launched, that we would dose it higher in that clinical trial with more refractory patients. So let's take a look on how state hospital psychiatrists prescribe quetiapine over the years. And we can look at the percentage of patients receiving quetiapine at doses above 500 milligrams a day, considered at that time a high dose, or 750 milligrams a day, considered at that time the top dose. It turns out that over the years, from 1998 to 2004, at the time the study was actually completed, the percentage of patients on quetiapine receiving a dose over 500 was about 50%. This didn't happen overnight, it took time, but this tells me that psychiatrists in the real world of treating patients didn't go by titrating to 300 or 400 and stopping. They continued on to over 500. In fact, about a third of the patients actually received quetiapine off-label at a dose exceeding the product label maximum recommendation. An off-label use of a drug at this dose so early in time tells me that perhaps the initial studies done with quetiapine were done with doses that were simply too low to control the psychopathology of the patients. Let's shift gears for a minute and now go over to the evidence that supports its use in bipolar disorder. This slide here shows the studies done for patients who've been stabilized on quetiapine. They all have bipolar disorder. What would happen if they were randomized to continue quetiapine or to receive placebo? Now, as you would guess, these patients would relapse if they were randomized to placebo, and in fact they did. They relapsed at a higher rate than those who were maintained